Tibial plateau fractures stand at the crossroads between articular precision and devastating trauma. These are periarticular injuries of the proximal tibia, and they rarely occur in isolation. More often than not, they arrive hand in hand with soft tissue compromise, swelling, and the looming risk of compartment syndrome. Diagnosis begins with plain knee radiographs, but in reality, a computed tomography scan is almost always required to appreciate the true extent of comminution and displacement, and to plan surgical intervention. Treatment, therefore, demands strategy. In some cases, urgent open reduction and internal fixation is pursued. In others, fixation is deliberately delayed, allowing soft tissue swelling to subside before definitive reconstruction can take place. Epidemiologically, these fractures account for 1 to 2% of all fractures, a seemingly small proportion, yet translating into more than 10 cases per 100,000 people each year. The average age of presentation is 52, but the distribution is bimodal, telling two very different stories. The first peak, men in their 40s, victims of high-energy trauma, car accidents, falls from height, devastating impacts. The second peak, women in their 70s, fragile bone yielding under the low-energy insult of a simple fall. Location 2 follows a pattern. The lateral plateau bears the brunt, fractured in 70 to 80% of cases. Bicondylar injuries involving both plateaus occur in 10 to 30%. Medial plateau fractures, although less frequent at 10 to 20%, often carry greater instability and more severe consequences. The etiology of tibial plateau fractures is written in the language of physics and bone quality. The vector of force, the magnitude of energy, and the resistance of the osseous structure dictate the fracture pattern. A valgus load translates its violence into the lateral plateau. A varus load punishes the medial side. Pure axial compression crushes both plateaus, producing bicondylar fractures. And when forces combine, dislocation can accompany fracture, a high-energy insult that usually devastates the medial plateau and more often than not, drags the soft tissues into the catastrophe. Energy matters. High-energy trauma generates complex patterns, dislocations, and extensive soft tissue injury. Low-energy mechanisms, by contrast, more often result in isolated lateral plateau fractures, particularly in osteoporotic bone. Yet even these apparently simpler injuries carry a silent burden. The menisci, ligaments, and neurovascular structures rarely escape unscathed. Meniscal tears are the most common companions. Lateral meniscal injuries are more frequent than medial and classically linked to Schatzker type 2 fractures. The risk rises sharply when articular depression exceeds 10 millimeters or condylar widening surpasses 6. Medial meniscal tears, in turn, are most often tied to the vertical shear of Schatzker type 4 fractures. The anterior cruciate ligament is not spared. Up to 1/4 of type 4 and 6 injuries show concomitant ACL rupture. Beyond ligaments and menisci, the stakes escalate further. Compartment syndrome lurks in the background, indifferent to the final radiographic result, yet decisive for functional outcome. Vascular injury, particularly in fracture dislocations, demands vigilance. Ankle brachial indices should be routine when dislocation is suspected. And among nerves, the common peroneal is the most vulnerable. especially in hyperextension bicondylar injuries where traction and compression converge.
To understand tibial plateau fractures, one must first return to the architecture of the knee. The tibial plateau is not a uniform surface, but a dual landscape. The lateral plateau, convex, more proximal, and composed of softer, less dense bone, and the medial plateau, concave, slightly distal, with a structure far stronger and more resistant to collapse. Together, they form the platform upon which the femoral condyles plide. This platform is not flat, it tilts. Posteriorly, the tibial slope averages 6 to 10 degrees, while a subtle 3-degree varus slope marks the mechanical alignment of the proximal tibia. Ligamentous anatomy dictates the stability of this joint. The anterior cruciate ligament inserts between the tibial spines, a sentinel against anterior tibial translation, and a secondary check against rotational instability. The posterior cruciate ligament anchors the tibia against posterior displacement, inserting deep within the posterior sulcus. Medially, the superficial MCL, broad and robust, inserts deep to the pes anserinus and resists valgus stress. The deep MCL fuses with the medial meniscus, offering an additional buttress. Laterally, the slender LCL finds its purchase on the fibular head, its role most critical in resisting varus low at 30 degrees of flexion. The menisci, too, shape this joint's destiny. The lateral meniscus covers more surface and enjoys greater mobility, which is why surgical exposure through submeniscal arthrotomy is often more forgiving. The medial meniscus, tethered by the coronary ligaments, is less mobile and therefore more vulnerable when stress is applied. Around this framework lie the muscular attachments, the patellar tendon anchoring the tibial tubercle, the iliotibial band inserting on Gerdy's tubercle, and the hamstrings converge medially at the pes anserinus. Posteriorly, the danger zone lies where the popliteal artery courses just behind the capsule before bifurcating into anterior and posterior tibial branches. The tibial nerve runs alongside it, governing plantar sensation and the motor function of plantar flexion and inversion. The common peroneal nerve, more exposed, curves around the fibular neck before dividing into its superficial branch, responsible for ankle eversion and dorsum foot sensation, and its deep branch, which powers dorsiflexion and supplies the first dorsal web space. It is this nerve that is so frequently endangered in hyperextension bicondylar injuries. Biomechanically, the medial plateau shoulders 60% of the load transmitted through the knee, while the lateral plateau bears 40%. Kinematically, motion arcs from 0 to 140 degrees, though walking requires no more than 70. During flexion, the medial plateau serves as the pivot point, concave, stable, while the lateral plateau, convex and mobile, allows the femoral condyle to roll back. The net effect produces the screw-home mechanism, the external rotation of the tibia during terminal extension, a subtle but essential movement that secures knee stability. Classification. No discussion of tibial plateau fractures is complete without classification, for it is here the pattern meets prognosis and dictates fixation strategy. The most widely used system is the Schatzkar classification. It divides these fractures into 6 distinct types, each reflecting a different vector of force, patient profile, and associated risk. Type 1 is the lateral split fracture, the simple cleavage through the lateral plateau, seen in younger patients with dense subchondral bone. Type 2 adds depression to the split, combining cleavage and collapse, and remains the most common of all patterns. Type 3 represents a pure depression of the lateral plateau, typically seen in elderly patients with osteoporotic bone, where force indents rather than splits. Type 4 shifts the violence medially, producing fractures of the medial plateau. These are often coupled with fracture dislocation and carry the highest risk of neurovascular and ligamentous injury. Type 5 involves both plateaus, a bicondylar fracture, but the tibial spines remain continuous with the diaphysis, a fragile bridge amidst chaos. Finally, type 6 represents metaphyseal-diaphyseal dissociation, where the articular block is separated entirely from the shaft, a devastating injury almost always associated with profound soft tissue compromise. Yet not all injuries fit neatly into Schalzker 6 boxes. For those that elude this system, particularly true fracture dislocations, the whole and more classification offers an alternative. Here, 5 types are described. Type 1, a coronal split. Type 2, an entire condylar fracture. Type 3, a rim avulsion of the lateral plateau. Type 4, a rim compression injury. And Type 5, a complex 4-part fracture. This system highlights instability, emphasizing the relationship between bone and joint congruity. Modern perspectives further divide the plateau into 3 columns: the medial, lateral, and posterior. This so-called 3-columned concept is particularly useful for identifying posterior plateau fractures, which are often overlooked in the traditional Schalzker system. More importantly, it guides fixation strategy, forcing the surgeon to think not in 2 dimensions but in 3, to consider stability from every angle and to reconstruct the tibial plateau as a structural whole.
The clinical presentation of tibial plateau fractures begins with the story of mechanism. High-energy trauma versus low-energy fall, the distinction is critical, for it speaks not only to the fracture pattern, but also to the hidden injuries that travel alongside. Patients are almost always unable to bear weight, the knee rendered unstable and painful. Baseline functional status and medical comorbidities must be recorded, for they shape the surgical plan as much as the radiograph. The physical examination begins with inspection. The knee must be viewed circumferentially, every surface scrutinized to rule out an open injury. The soft tissues demand equal attention, for their condition determines not just if surgery can be performed, but when. Palpation brings the next test: vigilance for compartment syndrome, the silent threat that can steal limb function within hours. Stability is assessed through varus and valgus stress. Any laxity greater than 10 degrees suggests true instability. Yet, in the acute setting, with pain and swelling dominating the exam, such maneuvers are often unreliable or deferred. When performed, they must be done in full extension to reveal the true competence of the ligaments. Finally, no examination is complete without a meticulous neurovascular survey. Pulses must be compared side to side, and if any asymmetries exist, ankle brachial index is mandatory. A reading below 0.9 is not a suggestion, but an imperative. Proceed with arteriography. The tibial and common peroneal nerves must be examined in detail, for their deficits may herald devastating injury hidden beneath the fracture line. Imaging. Radiographic evaluation is the cornerstone of diagnosis. Standard views include the anterior-posterior, lateral, and oblique projections. The oblique view, in particular, sharpens our eye to the subtle depressions of the plateau, revealing collapse that may be invisible in standard planes. A specialized plateau view, angled 10 degrees caudally to mirror the natural posterior slope, can further enhance detection. On the anterior-posterior film, a sclerotic band may betray a depressed articular surface. Malalignment across the joint line or a fracture line splitting the medial or lateral plateau may be evident. The lateral view demands care, for here, posterior medial fracture lines and abnormal tibial slope reveal themselves, signs easily overlooked but critical to management. When radiographs are equivocal, computed tomography is indispensable. A negative X-ray should not end suspicion if mechanism and exam success plateau injury. CT divides the fracture with surgical precision, exposing the degree of articular depression, the extent of comminution, and the trajectory of fracture planes. Posterior coronal splits, in particular, are best appreciated on axial and sagittal reconstruction. Even the presence of lipohemorrhosis within the joint is a silent indicator of an occult fracture. Importantly, CT should often be delayed until after external fixation if the soft tissues are swollen and unfit for immediate surgery, allowing safer preoperative planning once the envelope has settled. Magnetic resonance imaging plays a less defined but increasingly valuable role. While not routine, it can reveal associated meniscal and ligaments to injuries or expose occult fracture invisible to other modalities. It reminds us that the tibial plateau fracture is rarely an isolated insult. It is a herald of a broader injury pattern, often extending in cartilage, meniscus, and ligament. The differential diagnosis is broad. Distal femoral fractures, knee dislocations, patellar fractures, and tendon ruptures may all masquerade with swelling and inability to bear weight. Instability of the patellar, tears of the quadriceps tendon or the anterior cruciate ligament, and the meniscal injuries complete the spectrum. Each must be considered, for missing one can be as dangerous as mismanaging the fracture itself.
Treatment. Management of tibial plateau fractures balances the biology of bone and soft tissue against the mechanics of stability and alignment. Not every fracture requires the knife. Non-operative care is appropriate in select scenarios. Minimally displaced split or depressed fractures, low-energy injury stable under virus and valgus stress, non-ambulatory patients, or those whose comorbidities render surgery unsafe. These patients may be treated with patellar tendon-bearing casts, knee immobilizers, or hinged braces, preserving function while avoiding surgical risk. But most fractures that reach the surgeon's desk demand fixation. Open reduction and internal fixation remains the standard for instability, articular depression greater than 5 to 10 millimeters, condylar widening beyond 5 millimeters, or malalignment exceeding 10 degrees under stress. Medial plateau fractures and bicondylar patterns almost always fall into this operative category. Timing is critical. Acute fixation may be performed in lower energy fractures with minimal swelling, but in the setting of soft tissue compromise, staged protocols are preferred. Temporary knee-spanning external fixation stabilizes the limb while the soft tissue envelope recovers, after which delayed ORIF is performed. This staged strategy reduces complications while preserving outcomes. Predictors of success are clear. Restoration of joint stability is the strongest determinant of long-term function. Infection risk rises with bicondylar patterns, prolonged operative time, male sex, smoking, and pulmonary disease, but not with the timing of fixation relative to fasciotomy closure. Poor outcomes are associated with persistent ligamentous instability, meniscectomy, or malalignment exceeding 5 degrees, each altering biomechanics in ways that accelerate degenerative change. External fixation, sometimes with limited internal fixation, is reserved for the extreme cases, grossly contaminated open fractures, or comminution so severe that plating and screws cannot restore stability. These patients pay the price of higher malunion rates but salvage limb integrity. Finally, for patients older than 65 with osteoporotic bone, primary arthroplasty has emerged as a viable option.
In this population, total knee replacement not only avoids the complications of fixation failure, but also accelerates return to weight-bearing and often yields superior outcomes compared to revision arthroplasty following failed ORIF. Thus, the treatment of tibial plateau fractures is not a single path, but a spectrum, from bracing to external fixation, from internal fixation to arthroplasty. The choice depends not only on the fracture, but on the patient, the soft tissues, and the surgeon's ability to restore alignment and stability without compromising biology. In the end, it is this balance that defines outcome. A knee that is not only united, but stable, aligned, and functional. Techniques. The techniques of managing tibial plateau fractures span from conservative immobilization to complex dual incision plating. The choice depends on fracture pattern, soft tissue status, and patient profile, but the goals remain constant: restoration of alignment, preservation of stability, and protection of soft tissues. For low-energy, stable injuries, closed reduction with immobilization may suffice. Patients remain non-weight-bearing or partially weight-bearing in a hinged knee brace for 8 to 12 weeks. Early passive motion is emphasized to preserve articular mobility and prevent stiffness. When soft tissue swelling prohibits immediate fixation, provisional external fixation offers a critical bridge. Pins are placed outside the zones of planned definitive fixation, typically 2 in the femur and 2 in the tibial shaft. Axial traction is applied, allowing indirect reduction through ligamentotaxis. The frame is locked in slight flexion, protecting posterior neurovascular structures. Its advantages are clear. Swelling recedes, infection risk decreases, and length and alignment are restored, allowing more accurate preoperative CT planning. A transient rise in compartment pressures occurs during placement, but no consistent increase in compartment syndrome has been demonstrated. In certain scenarios, external fixation with limited internal fixation is employed. The articular surface is reduced percutaneously or through small incisions and stabilized with lag screws or wires. Screws must remain at least 14 millimeters from the joint line to avoid intracapsular penetration. This approach minimizes soft tissue insult, though with the higher malunion rates, pin site complications, and arthrofibrosis, with an incidence approaching 15% following temporary frames.
The definitive operation, however, is open reduction and internal fixation. Here, the surgeon's objectives are absolute: restoration of coronal and sagittal alignment, preservation of the native tibial slope, normalization of condylar width, and reconstitution of a congruent articular surface, all while minimizing further trauma to soft tissues. The anterolateral approach is most common, performed supine through a hockey stick or lazy S incision over Gerdy's tubercle. Submeniscal arthrotomy allows direct inspection of the joint and meniscus. For posteromedial fractures, exposure is gained between the pes anserinus and medial gastrocnemius, either supine in Figure 4 or prone. This extensile interval permits access to the posterolateral column when needed. The posterolateral approach, less common, demands retraction of the biceps and peroneal nerve laterally, with the lateral gastrocnemius retracted medially. Because of the neurovascular risks, it is used sparingly. Pure posterior approaches or midline incisions are reserved for shearing injuries, though at the cost of significant soft tissue stripping. Bicondylar fractures often require dual incisions and dual plate fixation, ensuring balanced stability. Reduction is assessed through submeniscal arthrotomy, fluoroscopy, or even arthroscopy. Depressed fragments are elevated via cortical windows, the void beneath them filled with bone graft or substitutes. Among grafts, calcium phosphate cement has proven superior. Highly compressive, osteoconductive,
porous and biodegradable, with less subsidence than traditional iliac crest grafts. Internal fixation follows the principles of absolute stability. Screws may suffice for isolated depressions or simple split fractures. Raft screws laid subchondraly and parallel to the joint line buttress elevated fragments. Lag screws placed perpendicular to fracture planes compress split components. But most patterns demand plate fixation. Conventional buttress plates serve partial articular fractures, particularly posteromedial splits. Locking periarticular plates, with their fixed angle stability, are indispensable for comminuted fractures and osteoporotic bone, mitigating varus collapse. Postoperatively, the limb is placed in a hinged brace with early passive motion encouraged. Even gentle mechanical compression on repaired osteochondral fragments improves chondrocyte survival. Wheat bearing remains restricted, non or partial, for 8 to 12 weeks, protecting the repair until union and stability are secured. Complications and prognosis. Even with meticulous technique, tibial plateau fractures carry significant risk of complication. The most common long-term adversary is post-traumatic arthritis. Within a decade, between a quarter and a third of patients will show radiographic degenerative change, and 3 to 7% will require total knee arthroplasty. The risk rises sharply with meniscoectomy, residual malalignment greater than 5 degrees, or persistent instability. The younger the patient, the more bicondylar the fracture, and the greater the comorbid burden, the higher the chance that arthroplasty will one day be necessary. Compartment syndrome represents the most feared acute complication, with an incidence of 7 to 20%. Risk peaks in Schatzker type 4 injuries, high-energy mechanisms, associated fibular fractures, long fracture lines, or combined plateau shaft disruptions. Young patients are particularly vulnerable. The treatment is immediate, emergent fasciotomy, no delay tolerated. Infection occurs in 2 to 11% of cases, driven by poor surgical timing in the presence of swelling, open injuries, and prolonged operative time. Treatment depends on stability. Irrigation, debridement, and IV antibiotics are standard. Hardware that is unstable or grossly contaminated must be removed. If the fracture is still unhealed but the implants remain secure, hardware may be retained while infection is suppressed. External fixation and staged revision ORIF provide a salvage path when infection and instability collide. Non-union and malunion are rare, 2 to 4%, owing to the rich cancellous blood supply. Yet they are more likely in type 6 fractures, in comminution, or where fixation is unstable. Revision osteosynthesis with grafting remains the solution. Knee stiffness is far more common, occurring in 10 to 25%, especially in bicondylar fractures. Risk rises with age, obesity, fracture severity, prolonged immobilization, or polytrauma. If flexion does not reach 90 degrees by 4 weeks, arthroscopic lysis of adhesions with manipulation under anesthesia is indicated. Loss of reduction, seen in 5 to 30%, signals inadequate fixation, osteoporotic bone, or unrecognized instability. The remedy is revision fixation, posteromedial buttress plating for coronal fragments that elude a lateral plate, for example. Deep vein thrombosis remains an underappreciated complication, with an incidence of 6% after surgery and 9% when treated non-operatively. Prognosis ultimately is mixed. Mortality at 1 year stands at 5%, reflecting the frailty of the injured population. Return to work is possible in 70 to 90% within a year, though many patients accept residual dysfunction or reduced workload. Range of motion averages 10 to 145 degrees by 12 months, a functional arc, though seldom identical to the uninjured knee.